A very good evening to respected seniors, colleagues, and dear friends. I'm Dr. Rujuta Machwe, Executive Committee Member, ISMSICS Maharashtra Chapter, and I welcome you all to the episode 8 of our webinar series, MSICS A to Z. Like many of the members, I am also down with URTI, but the show must go on. So please pardon me for my voice.
Yes,
Now, over to our President, Dr. Anil Shah sir, for the introduction and to start the session.
Okay. I'll share my screen. Is it audible?
No.
Yes.
Yes, sir, it is audible.
Yes,
No, he is audible, but video sound is not audible.
Video is not there. Can you hear?
Yeah.
Yes.
Okay.
That's what I meant to say.
Okay. 1 minute. I'll share my screen. Respected seniors and dear colleagues, on behalf of International Society of Manual Small Incision Cataract Surgery, I, Dr. Anil Shah, President for Maharashtra Chapter, welcome you, all the delegates, speakers, discussant on this wonderful series of webinar that is A to Z of Manual Small Incision Cataract Surgery. So for this series of webinar, our aim is to popularize smart SICS. It should be safe, cost effective with minimum learning curve, and it should be useful for community basis. Today is episode 8 and the topic for today's discussion is Incision, ideal wound construction for manual small incision cataract surgery. There are many variations in scleral incision which we all know, but today we will learn ideal scleral incision and also different varieties of scleral incision. So for this webinar, we have chairperson Dr. Prakash Marathe, Dr. Ranjit Singh Dadiwat, Dr. Parikshit Gokte, and the speakers who are expert in their field with the best of their knowledge and experience, Dr. Deepak Megur, Dr. M.S. Ravindra, Dr. Sunil Sangraj, and Dr. Nilutparna Devre. And to discuss this topic, we have expert discussant Dr. Kuresh Muskati, Dr. Kamaljeet Singh, Dr. Sudhir Mahashabde, and Dr. Srinivas Prabhu. I am really very much thankful to all the speakers and discussant for sharing their knowledge. Thank you very much once again. I'll stop sharing my screen. I will hand over to Dr. Ruchita. She will continue.
Thank you, sir. Yes. I would like to call upon the office bearers of ISMSICS. I think Dr. Amulya Sahu has not joined. I would request Dr. Parikshit Gokte, Vice Chairman, to say some few.
No, I think Dr. Anil Shah sir has already said everything that was to be said. And we really have four extremely experienced speakers. I mean, we all know Dr. S. Ravindran sir. And we have, of course, four great discussants. Without much ado, Let's wait up.
Thank you. Dr. Prakash Marathe,
Hello,
who's the
good
chairman of ISMSCS Maharashtra chapter.
Good evening, everyone. I think it is a wonderful webinar series designed by our president of Maharashtra chapter, Dr. Anil Shah. And I think after 7 episodes, even the energy and zeal is there, and people are appreciating this particular webinar series. And if you see that we are giving chance to many more speakers, like international speakers as well as national speakers, means outside Maharashtra state also. And the same way, even chairpersons and discussants are across the country, and they are sharing their knowledge. And today's topic is very, very important because tunnel reconstruction, wound reconstruction, and wound healing, it is the soul of this manual small incision cataract surgery. Most of the surgeons they try to do SICS, but if tunnel is not perfect, I think their aim is not served. So there are various skills to perform that tunnel in SICS surgery. And we have got experts like Dr. Deepak Megu, Dr. MS Sarvendra, and Dr. Nitupan Devri. They will be sharing their knowledge. And at the same time, Dr. Ranjit Singh Dhaliwal, Dr. Sudhir Mahashabde, and young star of SICS, Dr. Srinivas Prabhu is also there. We have specially invited these people to share their knowledge and discuss on this topic. I think this webinar series definitely is useful for all Maharashtra members as well as members across the country and even internationally. And Dr. Anil Shah has taken tremendous efforts under the able leadership of Dr. Sahu, Dr. Goramani, and Dr. Parikshit Gupte. I wish all the best for today's webinar. Over to you, Dr. Rujuta and Dr. Anil Shah.
Thank you.
Thank you, sir.
Thank you.
We are lucky today to have senior ophthalmologists as our chairpersons. Dr. Prakash Marathe is a managing committee member AIOS 2020-2023, past president MOS, trustee and past president Pune Ophthalmological Society, trustee and past president Indian Medical Association Pune, past senior vice president IMA Maharashtra State, convener National IMA Headquarter New Delhi, CWC member National IMA Headquarter New Delhi, chairman Maharashtra Chapter ISMSICS. The second chairperson, Dr. Anil Shah, sir. He is the president ISMSICS Maharashtra chapter. He is a private practitioner in Nandurbar since 1986. He has got research award MOS for snare and large foldable oil for MSICS, modified intracystic implant for DCR. MOS Best Research Private Practitioner Award. He has published many books and articles on Master Guide of MSICS, Manual FACO, Best Out of West, article for snare in AI Journal, international presentation, surgical demonstration, and paper presentation at national level. Our third chairperson is Dr. Ranjit Dhaliwal. As we all know, he is the exponent and pioneer of manual SICS, editor of Video Atlas of Ophthalmic Surgery, Master's Guide to Manual SICS, ready reckoner of Modern Cataract Surgery, Video Atlas of Ophthalmology Online, ISMSICS newsletter, e-newsletter. Is a consultant anterior segment consultant, eye infirmary number. The fourth chairperson is Dr. Parikshit Gupte. Is a vice chairperson, International Society of Manual Small Incision Cataract Surgery. Is working as director, Dr. Gupte Eye Clinic and Community Eye Care Foundation, Pune. Is a medical director of Atharva Netralaya and Research Center, Pune. Associate Professor of Ophthalmology, D.Y. Patil Medical College, Pune. Honorary Lecturer, School of Medicine, Dentistry and Biomedical Engineering, Queen's University, Belfast, United Kingdom. Is a member, Managing Committee, Maharashtra, AIOS from 2023 to 26, and is past president of Maharashtra Ophthalmic Society. His special interests are cataract, pediatric ophthalmology, strabismus, public health, glaucoma, ophthalmology residency training. So now I'll introduce our speakers for today. Are the slides visible?
Yes, yes.
Yes, we can see them.
So our first speaker is Dr. Deepak Megur. He is the Cataract and Glaucoma Department at Megur Eye Care Center, Bidar, Karnataka. Specializes in complex cataract surgeries. Teaching surgical skills through his YouTube channel, as everybody knows, past scientific committee chairman, Karnataka Ophthalmic Society, reviewer IGO. He has got many awards and orations. Few of them are CS Rashmi Overall Best Video Award, AIOC 2020, Best Paper of the Session Cataract, AIOC 2018, Best Free Paper Cataract, COSCON 5 times, Best Paper of the Session, APACRS 2014, Best Video Glaucoma Society of India 2010, Best Paper of the Session, AIOC 2010, MM Joshi Overall Best Paper Award, KOS 2009. He has got oration and other recognitions like Dr. Ravi Kumar Reddy Oration, late Dr. Nilima Pawadi Lifetime Achievement Award, and Dr. O. Gopal Krishna Young Ophthalmologist Award, APOS. Our second speaker is Dr. Mrs. Nilutparna Deori. She is Associate Consultant Department of Strabismus and Pediatric Ophthalmology at Sri Sankaradeva Netralaya, Guwahati, Assam. She has many publications, presentations, instruction courses at both national and international platforms. She has won the APAO Achievement Award, ARS International Ophthalmic Hero Award, Best of IGO Award, IGO Merit Award, etc. She has got keen interest in the teaching and training program of the DNB and fellow residents at Sri Sankaradeva Netralaya, and her areas of research are progressive myopia and oculogenetics. Dr. Sunil Thangaraj is a comprehensive ophthalmologist at Rural Eye Care Center in Sriramnagar, Andhra Pradesh. His surgical work includes cataract, cornea, and glaucoma. He has a lot of charitable surgical programs in Myanmar and Africa as well, which primarily includes surgical training of ophthalmologists there. He hosts his own YouTube channel where he has posted around 700 videos. Dr. M.S. Ravindra is Fellow Cornea Rochester Eye Institute, Fellow Sankar Netralaya, Managing Director Karthik Netralaya, President of Netra Jyoti Foundation, Founder Director Jyoti LASIK Vision Center, former Honorary Medical Director Bangalore West Lions Eye Hospital, Cornea Grafting Center, 1984 to 98. He is a former President Karnataka Ophthalmic Society and former President Bangalore Ophthalmic Society. So to make the discussion interesting and to have a lot of take-home messages, we have here discussants in our panel. These are Dr. Kuresh Maskati. I think he won't be able to join today. Dr. Kamaljeet Singh is Professor HOD, American Medical College, Allahabad, President Indian Intraocular Implant and Refractive Society 2006, Vice President UPSOS 2017. He's published a lot of books like SICS Manual FICO, awarded WHO Fellowship Medical Retina, Wills Eye Hospital, Philadelphia, USA, guest speaker for national and international conferences. Several research papers are there on his name, and he got a lot of orations, IRSI, RSI, UPSOS, Bihar SOS, etc. Dr. Sudhir Mahashabde, President and Medical Director, Indore Eye Hospital and Mahashabde Netralay, Director, Indore LASIK Laser Center, President, MP, Voluntary Health Association, operated in more than 1,400 eye camps through Indore Eye Hospital, Lions Club, etc., and performed more than 28,000 pre-cataract surgery with IL implantation. He has received various awards and orations. Lifetime Achievement Award 2022 from National Society of Prevention of Blindness, MP State Branch. Dr. Srinivas Prabhu is the Director, Prabhu Eye Center, Pune, Honorary at Ramakrishna Math Dispensary, Pune, Panel Consultant at Dinanath Mangeshwar Hospital. He has been doing SICS in remote places like Narayangaon and Jundar along with Pune for last 25 years. His motto is sutureless cataract surgery anywhere, anytime, for all in affordable prices. So we have got a huge gallery of experienced ophthalmologists will be telling us about the incision, which is the basic. And it is always said that well begun is half done. So without wasting much of a time, we'll start with the first speaker, Dr. Deepak Pregur. We'll be talking on ideal skeletal incision, complications, and management.
Dr. Megur, please unmute yourself. Hello, Dr. Deepak?
Yeah, I'm just doing that, sir.
Yes,
Just,
good. That's nice.
is my screen visible?
Yes.
Okay. First of all, I'd
Yes,
like to
sir.
thank the Dr. Anil Shah and the entire team of Maharashtra ISMSS for this opportunity. It's my pleasure to be here. So let me begin my presentation. And I feel in the modern era, the temporal scleral tunnel incision is the most evolved incision which we can have. And I just take you through one such case here. I always begin by making a small posterior groove. So this is something which I do just to fixate the globe. While I'm doing my tunneling. This is the way I fix my globe. A 6 millimeter long partial thickness groove is created using a 50 number blade. A crescent blade is used to create the scleral tunnel. I begin in the center, go into the cornea for about 1.5 millimeter, and then the tunneling is extended laterally to the left. And please note that the blade will be slightly tilted to compensate for the change in the curvature of the globe as I tunnel in the lateral aspect of the incisions. The scleral tunnel is extended on the other side as well. I'm creating two side ports. A 2.8 millimeter bevel-up sharp keratome is used to enter, and then the inner lip is enlarged. And please note that the cutting is done only as I enter, not while coming out. The cutting is done only when going in. As the extension is being done, please also note that the cutting edge is tilted up. This ensures that the inner lip always runs parallel to the limbus. A lot of attention needs to be given to the way we construct the scleral corneal tunnels. And the sad part is the internal incision is always ignored. We need to have this biconcave pattern of both the external and the internal incisions with respect to the limbus, which ensures greater stability of the wound, which results in long-term refractive stability. So, as Dr. Anisha had shown that there are multiple variations, but I believe that this variation where you have the inner lip to be always parallel to the limbus, that really adds a lot of security to the wound. So now moving on to the next form, which is the transconjunctival way of doing. I think this is probably the most just groove. Go through this because Dr. Sunil is going to cover in detail. Now using the crescent blade to... I think this is the most evolved form of scleral tunnel, if we can say so. Make the corneoscleral tunnel. And each one of us should aspire to reach a stage where we can comfortably do this. And that's being done in a typical fashion. So the principles are going to be the same. Only thing is how you stabilize the globe is a little bit challenged. Here I'm using a fixation ring, as you can see. So the viscoelastic is put inside it. So this is one way of stabilizing the globe a little bit more automatically, not putting the internal lip of the sclerocorneal tunnel. And care is ensured that the internal lip always runs parallel to the limbus. Although in this case, the distance of the internal lip from the limbus is quite long. So as you can see, the incision width here is about, say, 5 millimeter, because I'm going to divide the nucleus in the antechamber or in the bag and then remove. The point is, when you're doing a temporal incision, the amount of surgical induced astigmatism is extremely less. So even if you do a 6.5 millimeter or 7 millimeter, the amount of induced astigmatism is very less. Hardly you can induce more than 0.75, because the against the rule drift is so high that very what you want to flatten this horizontal meridian, we are rarely successful in that. So up to about 5 millimeter of incision or 6 millimeter hardly induces about 0.5 millimeter of astigmatism. In that case, these temporal incisions really compare very well with your phaco incisions as far as against the rule astigmatism is concerned. And when we do transconjunctival, it's absolutely, the effect is very much, the cosmetically it looks very well, especially because we need to understand many of the time the temporal bulbar conjunctiva is not great. It usually has some degeneration back the conjunctival like flap later, leading to some sort of a Dellen formation. And if we do a peritomy and then try to close it, you have to remove this part of to address this issue, I'm going to use a transconjunctival scleral incision. It's placed about 1.5 millimeter behind the limbus, and the globe is stabilized by a modified globe stabilizer. So again, you can go through it. The challenge here is, assessing the depth. And I'm sure Dr. Sunil is going to share a few tips on how to assess the depth when you go across the channel. But when you do this cosmetically, it's extremely well accepted by the patients. And sitting temporal and V2, obviously the best advantage is that you're going to induce extremely low amount of astigmatism. Now, moving on to some of the complications most beginner surgeons face or difficulties they have. So because I'm involved in training of a lot of young surgeons, I just take you through a couple of videos where why they struggle. So this is one surgeon who is in his early part of the career and trying to do it. Look at the stabilization is being held at the limbus. And one point is it's important to hold it very much close to limbus because that is where the conjunctiva and tenons are very much close. So you get a better grip of holding it. I would look at the way the blade is being used now. The surgeon is so skeptical to go into the cornea that he's not going much into the cornea. He's just stopping short of the limbus. And look at the point of entry. The point of entry is just at the limbus itself. So the concept of having an inner corneal wall, the surgeon doesn't have this, okay? So he's very eager not to go into the cornea. So what he's doing is basically trying to enlarge the incision, and the way he's cutting inside, the inner lip is always running towards the limbus. So let us compare this to and how the ideal way of doing. So you need to enter at least 1.5 millimeter beyond the limbus, and when you go inside, you should always tilt the blade up so that the inner lip always runs parallel to the limbus. See that whatever 1.5 millimeter of limbus, what we the intracorneal tunnel which we have, that is the one which is going to give us the self-sealing nature. And that concept, I think we need to make it very clear for our beginner surgeons. And another very common difficulty which most beginner surgeons will have is the way they fix the globe. The way they hold, because probably they'll be not taught well. You can see the way the surgeon is trying to fixate at the inferior limbus. That's also a good idea. But the globe is moving so much, in spite of having a very new blade, you can't cut across it because the globe is moving everywhere. So some basic aspects like, having a good fixation is something which we need to teach to these people. You have to have a good pair of forceps. And you're doing this tunneling, you cannot see the globe moving like this. The way we cut, the plane at which it cut, it's going to be in a different plane altogether. And most often than not, the way you stabilize, the amount of conjunctival trauma you're going to induce is also quite significant. So we need to teach the basic things like, just respecting the tissue and all. In many times, if you see in many of the junior surgeons doing, we end up having 180 degrees peritomy or even sometimes even 360 degrees. If they hold in the inferior part, it will ultimately join. So I think these are some of the basic concepts which I'd like to highlight. And I think with that, I'm going to conclude my presentation. Other speakers are there who are going to put it across in a much more detailed version. Thank you so much for the time, the opportunity. It was my pleasure to be here.
Thank you, sir. Thank you very much, sir.
Thank you so much. We'll have the question answer session after all the speakers have completed their presentations. So our second speaker is Dr. Nilutparna Deori, and the second speaker is Mr. Dr. M.S. Ravindra, and he'll be talking about my method of scleral tunnel incision. Over to you, Dr. Ravindra.
Ravindra, sir, you have to unmute yourself and... Hello, yeah, please. Yes, sir.
Is that visible?
Yes, sir. Yes, sir.
Fine. Is it playing?
Not yet. Yeah, now it has started playing.
Fine. Good evening. I'm really enjoying this meeting, and thanks for the invitation to the president and office bearers of MBOS. Few years ago, this is the technique of my surgery. I'll just show you how it was being done. Topical anesthesia. I had put a small amount of cotton at the site of incision. This is Tenon's conjunctiva combined incision right at the limbus. There's a very little amount of conjunctival flap, and there is a straight incision on the scleral side, about 1.5 millimeter away from the limbus. And I use a crescent blade. You're all very familiar with this, which goes up and anteriorly into the cornea. And that is how it depends upon the sharpness of the blade, how you move it. If you reuse the blade, then you may have to go only backwards or anteriorly or both the sides. Then I make a small incision and then continue with the surgery. Today, the same surgery, maybe about a year ago, I used to do this way. I directly enter at the periphery of the limbus, into the limbus and across the cornea, complete the rhexis, then enlarge it. Now, I'll just stop here. If you can see, the amount of sclera is very little here. I've taken a little bit of cornea, the entire limbus, and the sclera, there is a conjunctival flap there, and sclera is very little. This used to give me a surprise astigmatism, though it is on the temporal side. So I have migrated, whenever the cataract nucleus is large, I used to extend the anterior end of the tunnel to make it trapezoid. Sometimes I do it on only one side, sometimes on both the sides. So you can see here the surgeon who is planning a three-port vitrectomy, pars plana vitrectomy, is already put the ports. So I go and continue with the surgery. So I'm showing the entries that I generally make in various kinds of clinical situations. This is a young person, 25-year-old lady, non-ophthalmos. So I create a conjunctival flap, conjunctival Tenon's flap, as I initially told you, and pass through the sclera, limbus, and cornea to create a good tunnel there. Here I'm cutting as I'm coming backwards and enlarge the anterior end of the tunnel. Then this is a specially designed PMMA lens of power 60 diopters, which goes into the capsular bag. So at the end of the surgery, because in young patient, all the patients, wherever I do a scleral, we have always the fibrin glue, the conjunctiva Tenon's, the glue to the fibrin glue. This gives a phenomenal amount of cosmetic correction, and you don't have to band-aid the eye. So this tunnel can also be modified to make it 9 millimeters or even 10 millimeters. Same philosophy, conjunctiva Tenon's flap. See, I hardly push the conjunctiva Tenon's. You can see about 2 millimeters. That's all. I don't dissect under the conjunctiva. I don't pass the blades blindly under the conjunctiva Tenon's, which will create a lot of bleeding. If there is a bleeding from a particular vessel, I cauterize that vessel instead of uniformly doing the cautery at that area. So this is a large tunnel, maybe about 9.5 millimeter, depending upon the size of the lens that I'm planning to put. This is an albino under topical anesthesia again, and measure the diameter of the maximum diameter of the aniridial lens. I use aniridial lens for albinos, measure it, and extend the internal tunnel to suit the diameter of the lens. Then, see, this is a very versatile incision. You can put such a large lens. Patients are really very comfortable. The pupil size is about 2.5 millimeters. Normally, it comes at 4 or 5 millimeters, and you can customize it to 2.5 by talking to the company. And this gives excellent vision, contrast, and the reduction of photophobia for albinotic patients. And put this, if possible, inside the bag, or even if it's in sulcus, it doesn't really matter. You can see the entire lens haptic through the iris, which hardly has any pigment. And such a big tunnel has to be closed by single suture to minimize the astigmatism, form the chamber, pass the needle on one side, wait for some time, and then pass on the other side so that the alignment is perfect. Single suture in the center is probably the ideal one. And again, close the conjunctiva tenons with fibrin glue. You don't have to bandage, keep the eye open, and patient will enjoy the vision. This is how normally I do today. I take the incision about 1 millimeter behind on the steep axis of the cornea. Steep axis is we measure it and we use a toric marker to mark it. Here I'll show you what has happened here wrong. The Deepak said the anterior one should be concave, but then I don't mind even a straight incision, but here it has become convex anteriorly. So this would produce a little more of astigmatism. You'd have to be very careful in creating the tunnel so that in such a way that the incision anteriorly and posteriorly are parallel to each other. So here you can see straight line and a straight line there. This is slightly curvaceous and initially, but now I'm taking care that the edges of tunnel are straight to minimize the astigmatism. I can, depending upon the size of the nucleus, I either extend one side or both sides, and that's a lens which is being placed inside. So another case, I'll show you a couple of cases and I'll show you where we go wrong. Here it's little anterior. It would produce about points. You can see as I'm cutting through, it's coming little anteriorly on this side. So the blade has to be kept exactly parallel to the limbus to avoid the one edge of it going anteriorly. So this single incision is also useful for various other kinds of lenses like iris claw lens in a case of Marfan syndrome. So one tunnel is good enough, and these two are entries for enclaving the lens. So here I'm modifying the tunnel itself. There is a traumatic iridodialysis, and I'm making the incision at the site of iridodialysis. I'll remove the cataract. They're exactly about 1 millimeter away. I'm making a straight incision there. And instead of using a crescent, I use a blade itself to get into the anterior chamber and enter there and then remove the cataract. Then the iris is fixed to the floor of this initial incision using the scleral fixation suture. This is the 10-0 polypropylene Prolin suture, and the knots are placed inside the groove here. So one incision combines as both the fixing the iris as well as doing the cataract surgery. And again, this is closed with fibrin glue. Little anterior tunnel. Anything, sir? So various kinds of nuclei can be managed. I'll show you a couple of 2-3 cases and then conclude. Small pupil, very posterior polar cataract. There's another incision. Now I almost stopped doing the separate flap of the conjunctiva. It's exactly like phacoincision, but phacoincision starts from the cornea or anterior vascular loop. But here I'm starting from the conjunctival corneal side. So here I had done a pupilloplasty and then put the lens inside. This couple of care that you have to take is the channel as it passes through the stroma should be exactly in the mid-stromal. See, now I have entered it prematurely. Now I'm trying to enter it again in the same place, going anteriorly. I'm not very happy with the, I'm not entering the chamber there. Now I'm shifting I'll abandon this incision and I'll shift it a little more temporarily and create another incision. So even this tunnel is good enough. And this is not a leaking tunnel. The advantage is it's a quicker surgery. The management of conjunctiva tenons is not there. As I said, There are two kinds of forces. One is going anteriorly. The anterior force should be least. The sideway wriggling force has to be. Now, what I'm trying to do is probably this should be higher to control the depth of the blade. Blade has to be mid-stromal. If you go posteriorly, then it will try to make a frown incision. So if you remain mid-stromal, then this is a very high astigmatism, about 15 diopters of astigmatism being corrected by toric lens in a case of post-keratoplasty surgery. So that's probably one of the perfect incisions. I've done a rexis, then I enlarge it with a 5.2 millimeter blade and put a lens inside the eye after removal of the cataract. This is the distance I maintain now currently. This is about 1 millimeter away from the limbus. Go across, it goes about 1.5 to 2 millimeters inside the cornea. The entry and exit in the stroma depends upon how much of astigmatism I can correct. It can be 0.25 or it can be 1.25. That can be controlled by these methods. There is no need to hydrate the tunnel. At the end of it, just leave it and it's perfectly seals on its own. Cosmetically, the conjunctival opening is only about 2 millimeters. The much of the conjunctiva is stretched there. It doesn't open. So it heals, and next day, actually, you don't see a conjunctival opening at all. So these are the couple of videos that I would like to show. Yeah.
Thank you, sir, for the wonderful presentation. And I'm sure people must be having a lot of questions, but we'll keep it after the session, after all the presentations are over. Now, our third presenter would be Dr. Nilutparna Deori. She'll be talking about 2 mm Dr. Sahu incision. Over to you, Dr. Deori.
Thank you so much for the invitation. My slides will be shared from a different laptop because I'm having a little bit of problem. So good evening, everyone. Today I shall be only, at the very outset, I would like to thank Maharashtra Ophthalmological Society for giving me this wonderful opportunity. And today I shall only speak upon the wound ergonomics of Dr. Sahu's technique of 2 millimeter advanced MSICS. I have no financial disclosure in the presentation. So moving on to my next slide, I would, can you just move the slides, Dr. Sanavati? Yeah, my gratitude and acknowledgement to my mentors and my brother-in-law for his scientific inputs in this presentation. So next. Next. So I'll be talking only about the physics of the procedure. So let us take you through a schematic diagram. Now, if you look at the schematic diagram, you will see that the yellow line is represented on the globe. That is, the inner line is the corneal incision and the outer line is the scleral incision. That is the 2 millimeter incision that we are supposed to make in this tunnel. Now, here I would like to share with you that if you apply the Pythagoras theorem in this schematic diagram, the surface is given by the surface area, if you can see, and the D, that is the vertical component of this Pythagoras theorem, is by object 1, that is the wire vectors that we are going to use for delivery of the nucleus, and 2 is the nuclear fragment that is going to be delivered through this tunnel. And T is the restoring force that will be applied on either sides of the tunnel. And the superiorly, if you can see, the dome is the convex dome is the corneal surface. So according to the stress and the strain formula of Hooke's law, you will see that the stress on the membranes is given by the restoring force, that is the T per square unit area, that will be applied while trying to take out the nuclear fragment through a smaller incision. And the Pythagoras theorem here will be now converted in such a way that you'll have to apply a constant K to explain the change in the length length of the tunnel while taking it out, and we will look at the square root of the of both sides of the according to the Pythagoras theorem, the both sides of the right angle triangle. So going to the next slide. So we have to understand that there are two components that we are dealing with here now. One is the scleral elasticity and other is the corneal. Now, corneal elasticity does not have that elasticity as that we expected from the sclera. So the traverse, as you traverse from the sclera to the cornea, you will see that the amount that is the proportional limit of stretching of this membrane will be only adequate up to the limbus, but beyond the limbus, it will tear apart if you put too much of force in trying to pull out the nuclear fragment. So we'll go to the next slide. So if you look at this video now, you see that I have tried to make a 2 millimeter incision and straight away went into the cornea and tried to take out the nucleus. When I was trying to take out the nucleus, as there was a lot of, the video is playing a little faster actually, as there was no pockets created on either side. So the strain that I had actually applied on the sclera was beyond the limit of the stretch of the membrane. Therefore, the nuclear fragment caused a bursting effect at the mouth of the surface. So through this, if I'm trying to put in a PMMA IOL, it is actually going to tear apart the entire this scleral incision. So this is not the correct technique of doing a 2 millimeter incision, or rather, if you even extend it to 3 millimeter, it is not going to allow you to even put a 5.5 millimeter PMMA optic. So moving on to the next slide. So here again, I'm going to explain to you why this has happened, because there are two components now that will be acting on the this tunnel. That is the horizontal component and the vertical component. The horizontal component, that is the cos alpha component, will cancel each other, but the vertical component will double itself. Now why? Because the equilibrium for the object 2 is the limiting friction between the vectis and the nuclear fragment, which is increased by the friction between both the objects. So you have to pull it together. Therefore, the maximum acceleration that the object 2 can have also increased, thereby stretching the membrane. In order to avoid that, you have to create the pockets first by creating back cuts on either side of the tunnel, and then only applying your force to drag out the nucleus. So next. Okay, we'll go to the next slide now. The other one. We'll go to the video. Next slide, please. So here again, I'm trying to create a 2 millimeter incision. But before I have made the pockets on either side of the tunnel, I have already made my entry into the cornea. I have not entered into the anterior chamber, but the cornea. So now when I'm making the pockets on either side, actually inadvertently, I have increased the size of the scleral incision to 3 millimeter. So, but what has happened here, that since I have already created the pockets before bringing out the nuclear fragment, therefore, what I have done is that the stress that I have created in the tunnel was less. You can see how the nuclear fragment has come out, but it was within the proportional limit of the elasticity of the membrane. Therefore, once I have put in the PMMA IOL, it was bound by the Hooke's law that the sclera has again rebound back to its original position, but it has slightly increased to what I had actually expected to make. So next slide, please. So herein, I have to now focus that how am I going to bring out the nucleus here? So instead of putting the vectis straight and bringing it out, I have to now look at two components. One, should I bring the vectis horizontally or should I make it at an angulation? So I make it inclined at an angulation theta, such that the governing equation for the object will be easily pulled out through the tunnel. And in order to slide out the nucleus easily, we'll have to inject visco over the nuclear fragments continuously before delivering it, so that the friction between the endothelium of the cornea and the nuclear fragment is less, thereby creating less frictional force between both the nuclear fragment as well as the endothelium. So next, please. The next one. We'll go to the video directly. So herein you see this is the correct technique of doing the 2 millimeter incision. So you mark the 2 millimeter incision. After you do that, we have to initiate the side incisions. These are two horizontal, vertical incisions on either side of the main 2 millimeter incision. And while creating the pockets, you have to join it with the pockets up to the corneal surface. Only after that, once you have created that, then you make an entry into the cornea. If you are expecting to go ahead with a foldable IOL, you can extend up to 4 millimeter. And if you want to put a 5.5 millimeter optic PMMA IOL, you can go ahead with a 6 millimeter entry into the cornea. And hereby, you actually have created a proper tunnel and a proper pockets on either side. So you can take out the nuclear fragment either by bisecting it in the AC or in the bag, and that will be below the proportional limit of the elasticity of the scleral membrane. So there is no distortion of the main tunnel. So I think we'll move ahead. So I think we can move ahead to the next slide. So the idea behind this is that we have to create the back incisions first, create the pockets, and then only do the proceed with the nucleus delivery, but not in the manner that I had shown in the first two videos. Otherwise, you will end up creating more of endothelial damage and stress on the or tear apart the 2 millimeter incision. So thank you so much for your patient hearing. These are some of the studies we have already done before. Next slide, please. Next slide, please. Thank you so much.
Yeah, thank you, Dr. Nilutparna. A lot of physics involved, but we really strive hard to get the incision size lower and lower and lower. And this is one of the great achievements what Dr. Sahu has achieved to bring down the MSICS incision up to 2 mm. Thank you so much. Now our next speaker, Dr. Sunil Thangaraj, his sent presentation. His topic is transconjunctival limbal tunnel incision, merits and demerits. Mr. Rahul, you will have to play the PPT.
Good evening, everybody. At the outset, let me thank especially Dr. Anil Shah and the MSICS for inviting me to talk on transconjunctival small incision cataract surgery. And these are my financial disclosures, which are zilch. And what is the problem actually with the peritomy? Now, there are lots of problems. One is you have a large area of exposure. You definitely have to cauterize the scleral bed. Usually, there is post-op retraction of this conjunctiva. And usually, this peritomy needs either a conjunctival suture or cautery. Post-op rehabilitation is definitely prolonged, and it possibly can compromise future filtering surgery. So what are the advantages of a transconjunctival SICS? One is because there is no peritomy, of course there is faster rehabilitation. There is no need to cauterize, and you cannot cauterize the scleral bed. There is no conjunctival suture or cautery. Definitely post-op comfort is much better. Since there is only a slit opening and it heals very fast, future filtering surgery is possible. There's less chance of wound infection and possibility of less induced surgical astigmatism, and definitely it is a much more aesthetic procedure. Now the disadvantages, however, of a transconjunctival SICS is it is more difficult to perform. There is a learning curve involved. There is, because the blood obscures your view, it becomes difficult to dissect, and your assistant has to keep irrigating that area. And when you get a wound complication, then handling these wound complications are far more difficult than it is with a peritomy. But these are the post-op pictures of a transconjunctival SICS. The very next day, it's so beautiful to watch. And the surgical procedure. I'm using a side port knife to go through the conjunctiva, make my initial incision. I don't have a bridal suture in place, and that can pose a problem. And I'm dissecting out my scleral tunnel by feel. So it's about 1/3 to half thickness, and you can do it. And your assistant has to initially irrigate that area to wash away the blood. I then make my side port, go very carefully, enter with the keratome, and after staining the capsule, in this case, I'm doing my rexus through the side port with a 26 gauge bent needle. I then open up the incision with my keratome. Look how I am opening it up. Always forward movement, open it up completely, perform my hydrodissection, and in this case I am using my 2 dialer technique to rotate it out into the anterior chamber, then sandwich it between both these dialers and bring it out. I then of course proceed to remove the cortex and put in my intraocular lens, which is usually a rigid PMMA lens. You can put of course whatever lens you want. And I'm using the side port to take out the subincisional cortex. And that's the lens being put. That's just the finishing touches. Of course, you would remove the viscoelastic, and there is no suture, anything involved. And that's the complete procedure. Now, the problem is this is the main problem with the transconjunctival. When you are making the incision, since it is mainly due to feel, the beginners can make it a bit deep and actually expose the uvea. And this is the problem, because you have a difficulty in fixating the globe can rotate, especially if you don't have a bridal suture. It is very difficult to feel, to assess the depth, so you have a chance of going in deep. So I thought about this, and I then started using this for beginners, a fixed guard depth plate, which is about 300 microns. And with this, you can never go deep because it's a fixed depth blade. So that is one complication out of the way. After that, yes, there are the other problems of the blood and the dissection, but the main complication goes away. So even beginners can start this procedure. And with the transconjunctival, as with the peritomy, you can get complications, and there are many. You can get a superficial dissection, you can get a deep dissection, you can get a combination of both, you can get a frayed incision, you can make a posterior incision, whatever. And that is one of the examples there. You can see that the AC was lost, so I had a inadvertent entry into the anterior chamber, but I still managed. I'm just going to show, here is a superficial dissection. Look, I have dissected superficial. So all I do is just go into the initial incision, deepen it, and then make another tunnel under your superficial dissection. So you're creating another tunnel. Look at that. That's the superficial dissection, and that is the deeper incision. And this is actually pretty easy to do. Believe me, it looks tough, but it is easy to do. And the rest of the procedure is like any other SICS. Now you can also get a deep dissection, as is shown here, and now I am dissecting out a superficial flap from the overlying scleral flap. And this is more difficult. This takes experience, this takes skill, but it can be done. And depending on how much you have gone into the anterior chamber, you may or may not need a suture. Sometimes, however, your deep dissection can be so bad, as in this case. Look, it is really bad. So I have sutured the incision, and I've actually converted this case to a phaco. So there are a lot of possibilities to handle the complications as well. Thank you. I hope this was useful to you, and I thank the MSICS especially for giving me this opportunity. Thank you so much.
Thank you, Dr. Sunil Thangaraj. It was a wonderful presentation. And now I would like the chairpersons and the discussers to ask questions and add to our inputs. So I would request Dr. Kamaljeet Singh, Dr. Sudhir Mahashabde, Dr. Srinivas Prabhu to add their inputs, comments, and questions for the speakers.
Yes, please start the discussion.
Yeah,
Dr. Mahashabdi sir,
actually,
would you like to comment? Please unmute yourself.
am I audible?
Yes,
Yes, sir.
Prabhu. Yeah.
Yes, Dr.
Yeah,
Prabhu.
I am exclusively doing only SICS for 25 years. So I have been using this 300 micron, we call it as 300 micron blade for my all the cases. And since then, we get a fantastic plane for beginners. It is really good, or even for others. We, as the previous doctor, Dr. Thangaraj said, we just cannot go in some different plane. We get a really fantastic plane. And after listening to Dr. Thangaraj, I sometimes really feel that along with conjunctiva, taking the incision and then going into the cornea, because having done so many surgeries, I today still feel that if there is bleeding, even a small oozer is there while doing a SICS, I really start, nowadays the people, it is not for what people think, but they are literally comparing sort of how much time it's taken. So this blood keeps on coming in between in remote places. Sometimes we don't have that kind of assistant to even, give wash. And one sister is giving something, sometimes only the trolley is there with us and we are doing. So I feel better is spend some time in peritomy. I don't do a big peritomy like, from 9 o'clock to 3 o'clock. Hardly we do some 3 to 4 mm incision and just reflect it and do a beautiful incision even after cautery. In astigmatism is just 0.75 and we get a clear cut sclera we see and the cornea. And I feel anatomically, if you see, it is the corneoscleral junction. It is a cornea and sclera. It's not corneoconjunctival, right? So why one should have that one more layer above what you are doing? I feel it should be pure sclera. You can see some part of the blade. Only that much incision is done after 300 micron. One third, two third, you can say. We can see the blade very properly. We can do the pockets, and but that's it. That's what I. That's my personal take.
Dr. Ravindra, would you like to reply?
Yeah, Joshi, that you have a point. The visibility is greatest when you have done the phonics-based flap and then cauterize the prominent vessels or the bleeders, whatever it is, and then you have a very neat opening. Yeah, I fully agree that cauterization is not a taboo, but it should not be excessively cauterized. Have the lowest temperature, cut the sclera, and then it's going to ooze, and wait for some time, and then cauterize only the oozers. So many of these oozings will stop on its own if you apply a little pressure, and you have a right point there, and that will definitely be. See, it involves time. See, like I've done the same technique that you said, the phonics-based flap cutting at the limbus. Sometimes I leave a small gap because thinking that there are stem cells there which will heal up and replenish the cornea post-operatively. But see, the technique that I adopt is I'm always envious with the phaco surgery where you enter directly and then do the phaco and come out. So trying to pick up a leaf or page from phaco incision, I developed this. It was a tough road, very tough road. As you rightly said, what is a plane of my tunnel? If I go very deep, I'll have a front incision. If I go very superficial, then it may come outside. So it's a lot of efforts has to be put in. But now I've almost, abandoned the technique of conjunctival opening to in place for the direct entry for every case. I'm very comfortable. The surgery is fastness is not the criteria. The patient should get good vision, retain all the endothelial cells that are there. And if you want to correct astigmatism, you should be able to correct it. So basically, it's a neat surgery, and post-operatively, you don't see anything. The tunnel is not seen because conjunctiva is very small. Those sclera is 5.2 millimeter entry is there. Conjunctival opening because conjunctiva stretches. Sclera stretches, cornea doesn't stretch. Sclera stretches minimally, cornea doesn't stretch at all. Conjunctiva stretches maximally. So that's the layer. Conjunctiva heals marvelously in 24 hours time. And I find that the technique that I adopt where I use only the I don't use a crescent, but I use only the blades, sharp blades, has a role to play in modernization or uplifting your technique.
What are the chances of epithelial downgrowth in that case?
Nil. I've never seen. I've been doing it for 3-4 years now. I've never seen. Epithelial downgrowth occurs only when you have damaged endothelium. It's a well-established fact. If imagine few cells of epithelium has gone inside, body will recycle them, body will destroy them, not recycle them. And the endothelium, if you have damaged along with it, like we used to do with our intracapsular technique, then epithelial growth occurs. Here, there's no gap there for See, this scleral tunnel closes completely. So there's no question of anything growing inside that once you form the chamber. That's a good question. Yeah.
I think after hearing to the experts here, I think ISM SICS has given this platform, and routine SICS everyone knows. I think the expert technique done by Dr. Amulya Sahu, that 2 millimeter, and the technique done by Dr. Ravindra, it is nearer to FECO, what I should say. And it is working well in experts' hands. Not everybody should try this, because he had tried routine SICS to start with, and nowadays he has shifted to this particular technique. So basically, this platform is to show various techniques of SICS. Basically, what experts have been doing. It's not the general ophthalmologists should do all those techniques, because they must be having their own learning curve. And these techniques are best in their hands only, like Dr. Sahu and Dr. Ravindra. And basic thing which has been demonstrated by Dr. Deepak also, routinely, Dr. Prabhu said that most of them are doing routine SICS. That's what I feel. Yeah, Dr. Dhaliwal, Dr. Mahashabde sir.
Dr. Mahashabde sir, any comment on this new techniques?
Yeah, see, we keep on evolving. We started with a technique and observed somebody else doing B technique, and it's always a fancy to try to add something new to your techniques. So I would say that yes, seeing the different techniques, you come out at the end with what is good in your hands. And every technique has its points, plus and minus, and everything has its own learning curve. If you have access to some wet lab situation, then probably your learning curve may go little shorter, and you, without making more of the complications or problems during your learning, you can go advance to the techniques. I am being one of the original intracapsular surgeons, to which we turn this 360-degree turns to different techniques. So it's not bad to learn a new thing. Every time you see something new, or somebody managing a complication which you have not done earlier, you keep it in your mind and then add it to your own way. And sometimes you succeed, sometimes you not. But ultimately, it is the learning where you keep on changing or improving for the betterment of the patient, that you get a good and mainly, are you observing your own post-operative cases, following them and making notes, so that one can find out where I went wrong. Maybe at one single case doesn't make anything. Today I might have got a lot of complication in some big cascade of complications in one case, but next time I learn from that and try to improve and go to a better technique. I think the basic I teach to my students is to go for the good sharp knives. Whatever compromise we try to make, if we are going into a high volume surgery, then sometimes we share the instruments, and as for now the things are very economical. We should go ahead with the fresh knives for every case, and that would add to the clarity, the cleanliness of our surgery. Um, our movements have to be smooth. If we go with the book pictures, like, I mean, Dr. Amulya Sahu tells us, go like this, and you try to do that, maybe in a few cases you may have some problems, but ultimately you will learn it. We have all done it all our life, and uh, the it is the new generation who gets into. They start with. They have the better launchpad than us. What we had, the resources at our end when we started, and today what we are doing, our newer generation will have much better launchpad to start with, and but we must all keep on learning new techniques. I understand, and that is how uh, and how to manage the problems during such. That is more important. Say today I have tried for 2 millimeter incision and I failed, but what were my problems? If I note and try to clear them in the next time, and with 2, 3, 4, 5 cases, I'll overcome.
There's a question. Are there any training? Uh,
I would I would like to address my comments towards the all the mediocre surgeons out there rather than the skilled people on the panel, because those are the people I correlate myself with, and stick to any particular size. And small incision is not supposed to be all that small. Let it be 5 mm is good enough with the radial cuts, good enough, and you can leave it unsutured rather than going smaller and smaller and stretching the tunnel with all those instruments going in and the nucleus coming out. And this is a tip I got from Dr. Ravindra, I would say, long time back. Never stretch the tunnel. And that is a problem with all the phaco surgeries also. So we don't need to go all that small, I would say. And repeatability is what we need to aspire for. That's it. And
Dr.
wet labs, we can all create our own wet labs. That is how I have been learning as I was shifting from one surgery to the other.
Dr. Dhaliwal, I was slightly busy in a marriage, so although I had joined and I was listening to all the talks, especially Dr. Ravindran is my guru in every sphere. Dr. Anil Shah's and yours and all the videos I have seen, and I always find it that these youngsters are doing wonderful job today. They might make a straight incision or frown incision, but they are doing wonderful job. The cornea remains clear. The next day, you cannot recognize whether the phaco has been done or SICS has been done. So the results are very good, and the tunnel making is important. I always say that you take maximum time in making the tunnel, because if your tunnel is premature entry is done, or you have done a button holding, then that there would be problem. About cautery, I was listening to, there are some people who don't do any cautery, but a little bit of cauterization is always helpful. And bleed never goes inside the anterior chamber if you have made a perfect tunnel. That means a corneal valve is made, the blood will never go. It goes only when you extend the incision and you go towards the limbus. Then only perhaps I have seen that my residents and my even senior colleagues have hyphema the next day. So if you make a good tunnel, there would be no blood in the anterior chamber, whether you do cautery or not. And the results are excellent. This is what in nutshell I would say, because I was in a marriage. So I was just listening to your talks and having my food there. So thank you so much for including me in this session. I'll be more careful in attending the next webinar if I'm invited. Thank you so much.
there's a question that Are there any training programs to learn such new techniques like Dr. Sahu's technique or this transconjunctival limbal section and all? So, are there any training programs?
Yeah, I would like to answer to that. For Dr. Sahu's technique, we are giving it Sri Shankardeva Netralaya. This is an advanced technique, so students who are quite adapted to the conventional techniques of SICS can come over and join us for 2 weeks for the advanced techniques. It's at Sri Shankardeva Netralaya.
In our hospital, we do about 100 cataracts a day. Out of them, 10 cases of echo, 25 of SIVCS. And we have had trainees from US also and from our part of the country, that is UP and Delhi also. So you can come any day you want to come here. You will be given, if you little bit of knowledge of SICS, you will get cases in 1 week's time. You'll get a number of cases free of cost, no money charged, nothing. So you are always welcome in Allahabad, and you can learn a lot on SICS, our place, without any cost being any burden to the trainee there.
See about, can I answer?
Yes, sir.
About my technique, mine being a private setup in Bangalore, I will not be able to give hands up, but then hands-on training. But a lot of people come there, spend a day or two with me in the operation theater, and learn how to do it. See, the youngsters, if they are not, he said mediocre. Dr. Daliwal, there are no mediocre people. It's a mediocre learning. Everybody can master the technique. See, a good tech surgeon will have dozens of tips which you can't pick up from any YouTube video. Unless you discuss with him, like in earlier days, in conferences, as soon as the lecture is over, you come outside. There are about 20 people come and ask 100 questions. Today, that's stopped. Nobody comes and talks to you, and they watch YouTube and they think that they're going to learn it. It's a very slow process. Yes, they will learn, but it's a very slow process. The interaction with the surgeon is probably the most important way of learning. And if you're watching the surgery, at the end of watching the surgery, record the surgery and sit with the surgeon. He'll run through the surgery and you can actually discuss with him what did he do exactly in that. So a master surgeon does something and you go and do it and you'll be thoroughly disappointed because there are a lot of techniques involved. See, even doing a tunnel, I have learned with great difficulty that the pressure anterior thrust of the blade has to be minimum. You should be wriggling movement to get a good position of the tunnel in the stroma. So you need to do a lot of surgeries just to learn a single point, and that you can hand over to an youngster if he is keen in learning. The other good way is you sit in a remote place, record your video, edit it, run it fast, and share it with, now, see, video recording is so simple now. Share it with a surgeon. He will, in his spare time, will give a feedback. A lot of people send videos to me, then I'll just give a feedback to them. So that way, as a private practitioner, I can contribute in somebody learning by subtle ways. But I would again say, if you think that you're going to learn by watching YouTube video, you can refine a small step. But then if you want to study, get the entire thing, you'll be disappointed. That's my humble submission.
Thank you, sir. In continuation to this, I have got a question. So many youngsters, basically, when they pass their DNB or their MS, they are after some short-term or long-term fellowship in SICS. And then there are various experts from all parts of the country here. Do you have that facility of short-term fellowship or long-term fellowship at your centers related to SICS?
In my place, yes, if somebody wants to stay for about, say, 6 months' time, they can. See, cataract surgery is a big thing. It's just not surgery, which is 8 minutes job. So we're working up and complicated cases, planning the surgery, identifying the IOL for the particular needs. It's a big vast surface. So they can apply and they can join, and at some point of time we'll give hands-on surgeries.
Yes, sir. Thank you. Thank you.
May I, sir?
Yeah.
At Shankardava Netralaya, sir, we do give basic SICS training for 2 months. And for the advanced courses, yes, those who have already completed almost maximum cases in our, I have already told, they are quite apt with the basic conventional SICS. We give a 2 weeks training also for the advanced, only 2 millimeter advanced course.
Thank you. Thank you. Dr. Kamalji Singh, at your place, is it available, long term or short term? I think he's offline.
Short term, we have lots of postgraduates in our department. So for short term, you can always come and go and learn it in a short time. And because many people, those who come to us, they know about the surgery already. So they have to simply be given the surgery and they do it well. In UP, most of the surgeons are doing SICS. So if they want to improve upon their techniques, they come to us and we give them training for 15 days. If they are novice, then of course we need to give at least 2 months for the training.
Thank you. Thank you, sir. Thank you.
And
We also have the short term as well as long term fellowship. Interested people can apply.
That's great. That's great.
I would like
There's a question for Dr. Meghur, sir. Please mention about your fixation technique.
Yeah, I think you can have many techniques. The one which I prefer is either you use a fixation ring, which I showed in my video. It's a very automatic way of stabilizing the globe, especially when you're doing a transconjunctival incision. When you're doing a conjunctival incision, if I do a conjunctival incision, I make a small posterior scleral groove, not I hold at the scleral groove rather than in the conjunctiva or the limbus, as is typically taught. When I'm doing a transconjunctival, I use a fixation ring so that the globe is held steady and I don't hold any forceps for that. So that gives a lot of stability to it. So these are my 2 ways of modifications of stabilizing the globe.
So which forceps do you use? Any specifications about that?
Limbs forceps will do. That should be fine.
Forceps.
Yeah.
Limbs forceps.
Limbs
Is it
You
traumatic? A bit
can
traumatic.
use a episcleral forceps are also there. You can use that also. And many people use limbs, as sir has said.
And here I would like to take, excuse me, I would like to utilize this opportunity to thank Dr. Anil Shah and MOS chapter to have started using these 2 platforms on the Facebook and YouTube, which we had started during the COVID for ISMS-ICS, and we have a whole lot of most of the webinars except for the Karnataka, because they have their own channel, and at these 2 or 3 places we can access all these discussions also. So thank you, sir.
Thank you, sir. Thank you.
Dr. Deepak, you can Karnataka.
Yeah, we can share the link, no, sir. We can share the link of all our thing to you.
I'll make a playlist on the main ISMS-ICS YouTube channel and of all the videos in your channel.
Yeah.
We'll make a playlist.
The channel, we can just share the link of all the episodes which you have had.
Yes.
And you can put it in the main.
They're long, 1 hour, 1.5 hours, but then it has a lot of content.
I think we have been following the same in Maharashtra under the leadership of Dr. Anil Shah.
Yes. If there are no more questions, I would like to invite the chairpersons for their concluding remarks. Dr. Prakash Marathe.
I think it was a wonderful session about the tunnel and wound reconstruction and various techniques. And we have seen the special techniques by Dr. Ravindra and Dr. Amulya Sahu's technique shown by Dr. Nilutparna. I think these are some special techniques. Even I didn't see Dr. Ravindra's technique because he has shown his journey starting from routines SICS to near to phaco SICS. And even 2 millimeter phaco, 2 millimeter SICS, most of the surgeons, they do not believe. But we have observed that particular technique when Dr. Sahu himself has operated in various conferences. And I think people like Nilutparna, they have learned and they have been demonstrating that technique to their places. This was the big achievement of this particular session today. And this webinar definitely is helpful, and people like Dr. Ravindra, Dr. Megur, and Dr. from various places, they have been participating in spreading the knowledge of small incision cataract surgery. And wonderful participation by Dr. Mahashabde, Dr. Dhaliwal, and Dr. Kamalji Singh here. And Dr. Anil Shah and Dr. Rujuta, they have been doing great job. I'm very happy as chairperson of ISMSS Maharashtra chapter that this particular training program definitely will be useful for youngsters as well as senior ophthalmologists across the country, and not only the country but across the globe. It was a wonderful webinar. I'm thankful to each and everyone here.
Thank you.
Thank you, sir. Dr. Ranjit Dhaliwal.
I would just like to add one personal thing here. I've still not been able to overcome that mental block. I do very, very, very few surgeries these days, and I'm more into just discussing these things, and that too more on my phone. I keep getting calls from youngsters about the problems they are facing, and most of them are not surgical, I would say, and how to develop surgeries and how to develop centers, the small grassroots level centers, I would say. So that's it. And if ever there is some counselor speaking on any of these, I would like to attend. Maybe he's able to make me start doing it all over again. Thank you. It's been
And
a
not,
wonderful experience being
not
here.
to forget my friend Dr. Srinivas Prabhu, who is again from Pune. He was reluctant to join this particular webinar, but definitely his experience will also be helpful, because in his practice of ophthalmology, he is doing SICS, SICS, and SICS only. So he's the man of SICS. So we would like to introduce such people to our webinar series in future also. And Dr. Srinivas will also be delivering your technique in future in one of our webinars.
Definitely.
Dr. Parikshit Gopte. Is he there, Dr. Parikshit?
He is muted.
Okay. Dr. Anil Shah, sir.
I am really very much thankful to all the speakers, Dr. Deepak Megur, Dr. MS Ravindra, Dr. Nilparna Devre, and Dr. Sunil Tangraj, and also all the discussant who has given their expert knowledges to all of us and make this webinar wonderful. Actually, I am also a fan of manual small incision cataract surgery, and I do superior temporal transconjunctival limbal incision. It is a 3 millimeter incision, and through snare I do all these surgeries. In old days, when these crescent blades and 2.8 millimeter blade were not available, we used to do it all these surgeries with 15 number blade and 11 number blade. But with the time, we have changed, and now we are using all these types of blade. I am again thankful to all the speakers and all the members and all the discussion for giving this their time and making this webinar a wonderful episode. Thank you very much.
Thank you, sir.
Thank you.
Dr. Parikshit is available, or yes, Dr. Parikshit, we would like to hear concluding remarks from you as a chairperson.
Unmute.
Yourself.
I think he must be having some connectivity issue. Dr. Parikshit, unmute yourself. Unmute.
Not able to communicate.
No, I think he's not able to get.
Rujita, you can sum up now. If
You
there
can
is
sum up and make a vote
Before
of thanks.
concluding, I would like to thank all the speakers for their wonderful videos, presentations, and a lot of take-home messages. I would like to thank all the chairpersons, discussants, the office bearer of ISMSAS, and the audience, obviously. Thank Mr. Rahul from Entod Pharma for the technical assistance. Dr. Parikshit, are you there?
Yeah, ma'am. I think I
Finally, you could make it.
Thank you.
Unmute. You are frozen.
Unmute yourself, Dr. Parikshit.
He is muted.
No, he's not able to get. So thank you once again. And I would like to conclude the session now.
Thank you. Thank you, everyone.
Good night.
Good night.
Thank you, everyone.
Thank you for your
Thank you, sir.
participation.
Thank you.
Good night. Good night.
Thanks, Dr. Anil Shah. You're
Yes,
doing
sir.
wonderful
Thank you.
job. Wonderful
Thank you very
job.
much, sir. So it is because of you and all the speakers. It's a wonderful job, sir. Thank you very much.
Thank you all.
Thank you.
Thank you. Good night, everyone.
Good night.
Good
Prabhu,
night.
thank you very much. Yes.
Thank you. Thank you.